Thank you, Adrian, and I would like to take the opportunity to thank the organizer for inviting me here. Still having a little bit of jet lag, but I'm excited as well because it's the first time ever I come to England to present. I think it's very exciting clinical outcome of the collaboration between LifeArc and SinoMab. Now, SM17, it is a first-in-class platform therapy because it doesn't really just work on one single disease indication. We found it actually has multiple disease indication with a huge potential. And then it targets a receptor called IL-17RB. Because we use IL-25 receptor to talk to a lot of investors because people got confused. IL-17RB with IL-17. So we use IL-25 receptor to indicate us. But I got to go back to the history of how the SM17 became the SM17 in the first place. It was discovered and humanized by LifeArc and Andrew McKenzie of Cambridge LMB. And then eventually it licensed to SinoMab for clinical development with this initial information about its potential, but basically for asthma and IPF. And then SinoMab converted the antibody into IgG4 human version, and then we start doing the IND-enabling studies, etc. But here's the abstract documenting the initial effort of Andrew McKenzie and LifeArc in identifying the clinical potential of the antibody for treatment of asthma and IPF, and as well as maybe UC. And then after the licensing, that actually we were allowed to go global with this for development. And then we have licensing the whole patent family. And then the partnering support, actually, LifeArc has been extremely supportive of our development. And I'll talk with other people. And then I think that if you can partner with LifeArc, actually it's a blessing. Now, the antibody itself actually targets the yellow part of the receptor. It's called IL-17RB. It can be in two forms. One is heterodimer. In the form of heterodimer, actually it binds to a liamine called IL-25. But it also exists in homodimer form. And it exists as homodimer, it binds to another cytokine called IL-17B, the function of which is not very clear. But IL-25 is one of those alarmins. Then people would think that it acts on type 2 immunity, very similar to the pathway of dupilumab that blocks IL-4, IL-13, and IL-6, and IL-9 and IL-13. We took the antibody and then we studied in our lab in Hong Kong, and we found that actually it, other than targeting asthma and IPF, it actually will block Th17 and under the skin with dermatology as well. So we decided we were going to explore different disease indications other than the one that actually we were aware of. And then the first one that we were particularly interested is atopic dermatitis. Number one, because of the success of Dupixent. Actually, the last year, the revenue generated somewhat around $18.5 billion. So the market is huge. And secondly, because it is there is some deficiency in the marketed product because all existing products. For atopic dermatitis patients, they are concerned about three things. Number one is the drug is safe. Second, will it induce skin healing? And third, hopefully it can alleviate itch. But unfortunately, all the marketed products, including those with clinical data as of today, other than SM17, they can only deal with two of the three criteria for atopic dermatitis. And at the time, including Johnson & Johnson and everybody else, they're trying to find an optimal treatment that can deal with all three criteria: itch, skin healing, and safety. Now, we can compare it. JAK inhibitor is extremely effective, but it's not safe. It has a black box warning. So the sale is not as good as Dupixent. Dupixent is good for skin healing, but it's not very good for itch alleviation. It's safe though. So this is the situation that other people are joining into the race. And then we were told that actually it's a crowded area. But it's crowded if you do not have differentiation. Once you have differentiation, maybe it's not that crowded. And then we first test it in the animal model to see whether it works or not. And we use a standard DNF-induced mouse model, and we want to compare it with the most powerful drug at the time, which is upadacitinib, which is a JAK inhibitor. We saw the skin healing effect very similar to upadacitinib, but to our surprise, we saw a very rapid itch alleviation to the extent comparable to that of upadacitinib. Remember that alarmins IL-25 people will consider it to be a type 2 immunity inhibitor pathway thing. So it wouldn't expect to exceed the therapeutic efficacies of Dupixent because it's still along the same pathway. So that is sort of like a to our surprise. But this is important because that shows differentiation. We really want to see whether the itch alleviation is real or not. And then we also want to compare it with different other comparator antibodies or treatments. So that's what we did. We developed a chronic atopic dermatitis mouse model, and we compare it with different antibodies, including antibody targeting the alarmins, the cytokine, the IL-25, as well as upadacitinib. And then we use, because it's a mouse model, we use mouse surrogate antibodies similar to Dupixent that will target our 4 receptor alpha, and then with SM17. You can see the itch and scratching behavior suppression. It's extremely powerful with SM17 compared to upadacitinib and dupilumab similar, as well as when you target the IL-25 cytokines with an antibody. So this is a very consistent sort of data because we do it almost like a placebo-controlled double-blind assay because it's so important for us. This is the differentiation that we want to see the other product wouldn't be able to demonstrate. So we also want to find out why, because if it is a type 2 immunity pathway blocker, how come we will observe like anti-itch effect better than dupilumab, even better than upadacitinib? So we start to understand whether it has certain function under the skins. So we took out some keratinocytes and start to look at IL-25 induction. And we can see that it can reduce the filigreens of keratinocyte, and that it can induce proliferation, induce CCL2, 6-3, CL1, and IL-18 releases. But when we add the antibody SM17, we can have very good induction of filigrein and good suppression of the proliferation and all these chemokines and IL-18 as versus to the anti-IL-25 antibody versus upadacitinib. So there is something that actually happening under the skin that is not found in other antibodies. So here we hypothesize the mechanism. Although actually alarms actually go through the standard systemic type 2 immunity pathway, eventually working on reducing the release of IL-4, IL-13, IL-9, and as well as in IL-4. That is similar to Dupixent. But we also have something that actually happened under the skin. And on the skin, we know that actually expresses IL-17RB. When it binds to IL-25, it induced something called ET1, which is an itch mediator, as well as working on the dermal fibroblast, suppressing the release of periostein. So we have very clear data showing that it actually is the case. So it seems to us that SM17 actually works in two pathways. One is the canonical type 2 immunity pathway, causing the skin clearance, but also under the skin, causing a rapid alleviation of itch, as well as improving the skin healing process as well. So that were only the animal data. So we really want to see it in human. So then the last year, in April, actually we got all this phase 1b proof of concept clinical trial. We have 3 groups of cohorts. One is the low dose, 12 patients, and the other is a high dose, 12 patients. And then we have 8 patients for placebo groups. As you can see that the low dose group versus the high dose group, we look for several criteria. One is the NRS4, that is the indication of itch alleviation. And then the other is EASI-75, the recovering almost like 75%, as well as the IGA-01, almost like a clearance. As you can see that actually in the low dose and the high dose, and especially on itch, even at low dose, we achieve 66.7% of the 12 patients achieving NRS4. And then the high dose even, we have not seen anything like that as of today. We have 91% of patients achieving NRS4. That means like 11 out of 12 achieved itch alleviation to their satisfaction. And then we compare the EASI-75. Also, we have a dose response. The low dose achieving about around 50%, and the high dose is 75%, as well as 25% for the IGA-0 and for low dose, 41.7% for the high dose. And this information actually, we just line it up with NRS4, EASI-75, etc., compare with all available treatment modality and see which one is better. As you can see, NRS4, SM17 outperforms every available treatment, including nemolizumab, which is developed purely for itch alleviation. And as you can see that they achieve 65% with concomitant use of topical steroid. But even our low dose achieved that with monotherapy. So the itch alleviation is real, and then it's very differentiating. And as well as the EASI-75 and IGA-01, we're at the top quality one. And since we have done our phase 1 trial in the US with 77 healthy volunteers, and then we did a bridging study in China with 32 healthy volunteers. The safety profile, we have at least 150 individuals or patients exposed to the drug, and it's confirmed to be extremely safe. And this, I think it's not better, it would be comparable to Dupixent, but we think that it's better than that. So then we expand the indication into other diseases, including like other than asthma, CRS with nasal polyp, as well as IPF. Now, these are things that we don't see differentiation yet. Okay? But one thing we notice actually is it's very anti-fibrotic in the way that it suppresses Th17, as well as other fibrotic factors like IL-6, CTGF, and TGF-beta. So we observe that, but that we have to identify disease indication that actually have differentiation. Otherwise, it's not worth developing. So we look into a different disease that will have unmet medical needs. And we look at IBD, especially for Crohn's disease. First, this is a huge disease indication. Even though we have a lot of treatment modalities available, but none of them are satisfactory for the treatment of something called strictures, which is caused by fibrosis in the gut and leading to surgery removal of the blocked section of the gut. So we would like to see if the antibody will be effective for treatment. I think it's running out of time. So you can see that it works for Crohn's disease model. And then you can see that actually the anti-fibrotic effect is pretty clear. And then with the treatment, it's clear. Blue means like a collagen deposition. And then we can see the corresponding suppression of all these fibrotic factors. And then we also demonstrated it is useful for UC. And basically, here's the summary of the SM17. We will do clinical trials, phase 2, to find the best dose for atopic dermatitis, and then we are going to do the IBD clinical trial as well in the near future. I think I'll end it here. Well done that.